Hello future doctors, how are you all? Welcome back to MedSteps YouTube channel. So today we are going to discuss very important and high yield topic. You can see in your family members, you can see in hospital, wherever you are going, it like old age, you can see hypertension. In young age also you can see hypertension cases. Okay, so in this video we are going to discuss about silent killer, means hypertension, clinical features, and how we have to manage that patient, and what are the causes and everything, pathophysiology, everything we are going to discuss about each and like base from basic to advanced. Okay, so without time waste, myself, I am Medico Anand Kumar Jana, final year medical student. So without time waste, we will go in our video. So let's start. So as usual, clinical scenario. If you are seeing this clinical scenario, you can see here you can see in this one picture, 55 years old male with type 2 diabetes presents for routine checkup. When patient came for routine checkup, you can see here the blood pressure is 148 systolic, 92 mmHg diastolic. The average of 3 readings, then only you can check this 148 by 92, that is average value. In the patient we can't see no symptoms. So in labs, the creatinine level like 1.1 milligram per deciliter, the potassium level we can see 4.2 millimole per liter. The ECG findings we can see left ventricular hypertrophy. So what's the next best step? So in this patient, the average findings like 148 by 92, and patient have diabetes also. And another thing, no symptoms, but in labs the creatinine level increased and the potassium level also increased. The potassium like normal, 3.45 to 4.45 is the normal value, so you can see 4.2. But in ECG, the left ventricular hypertrophy we can see. So what's the next best step means? First option is lifestyle modification only. No, because in lifestyle modification we have to do before, but now we have to start ACE inhibitors, means angiotensin converting enzyme inhibitors. We have to start beta blockers, no, and no treatment needed, no. So the option is, the right answer is ACE inhibitors we have to start. Why? We will discuss in management step by step, but first start ACE inhibitors. Because if you are seeing in this patient, the patient age is 55 years old male with stage 2 hypertension, and the patient have diabetes mellitus also. So in ACE inhibitors is the main thing for protecting kidneys. Patient have diabetes, so very prone to get acute kidney injury. So for saving kidney, so we have to start ACE inhibitors, and we have to follow some algorithm for diagnosing hypertension. So first we have to do lifestyle modifications, and we have to assess the severity and comorbidities. Then after we have to start first line pharmacological management, and we have to monitor blood pressure every time, and we have to, based on the blood pressure readings, we have to adjust the dosage, or we have to add some other combination drugs. Okay, and for why we are doing this thing? For preventing complications. So before hypertension, we have to understand first what it is. Hypertension means increasing blood pressure. So blood pressure is the force exerted by blood in arterial walls. If you are seeing this image, you can see here, this is the hypertension. In hypertension means the high blood pressure. So what it means? High blood pressure means it's like, you can see the force of blood exerted on artery walls. So here we have two components, we can see here, that is 130 plus and 80 plus. What it is? The high value, the systolic blood pressure. The systolic blood pressure means whenever that heart getting contraction, the pressure during contraction, ventricular contraction, we call that is systolic. If the pressure during ventricular relaxation, that thing we call diastole. So here we have to check systolic and diastolic. Based on that things, we have to check the blood pressure. Okay, so here the normal blood pressure is 120 by 80 mmHg. How we can check blood pressure means blood pressure equal to cardiac output into peripheral vascular resistance. So this is the main formula for checking blood pressure. Okay, so this equation is the key to understand hypertension. So what it means, what hypertension, if anyone asking definition of hypertension means, we have to tell persistent elevation of systemic arterial blood pressure. So persistent, without knowing, always it will increase. So that elevation of systolic blood pressure, systolic arterial blood pressure is known as hypertension. We can see here we have some criteria based on ACC and AHA in 2017. The normal blood pressure is less than 120 by less than 80 mmHg. And the elevated blood pressure like 120 to 129 mmHg of systolic. The diastolic less than 80 mmHg, that is the elevated blood pressure. And we have some stage 1 hypertension and stage 2 hypertension. In stage 1 hypertension, the systolic value like 130 to 139 by 80 to 89 mmHg. In stage 2 hypertension, the greater than equal to 140 systolic and diastolic greater than equal to 90 mmHg. So for your exams, based on WHO or ISH, the normal value of blood pressure that is greater than equal to 140 by greater than equal to 90 mmHg. Based on patient age, based on patient comorbidities, we have to treat hypertension. Okay, so these are the main introduction of hypertension. So causes of hypertension. If you are seeing causes, the causes is divided into two different types. One is primary hypertension, second one secondary hypertension. The primary hypertension will be like idiopathic. Idiopathic means unknown cause. It's maybe because of 90 to 95% of cases we have to see primary hypertension. In primary hypertension, it's like because of multi factors. The multi factors like it's because of age, it's because of obesity, it's because of sedentary life, like many things. It's because of sex, like male or females, based on their work, based on their occupation or stress levels. These are the things will caused by primary hypertension. In secondary hypertension, it's based on because of some pathological condition, the blood pressure will increase. So the secondary hypertension we can say like renal. In renal cases, renal kidney disease and renal artery stenosis can cause secondary hypertension. Second one, endocrine. In endocrine system, we can see hyperaldosteronism and Cushing syndrome or pheochromocytoma. Cushing syndrome because of releasing more amount of adrenaline and aldosterone, and pheochromocytoma, okay, because of activating more amount of sympathetic nervous system, it will cause secondary hypertension. Next one, hypothyroidism and hyperthyroidism. Because of releasing of more amount of thyroid hormone or reducing of thyroid hormone, the body will react and it will cause hypertension. Next one, vascular problems like coarctation of aorta or aortic dissection. Okay, because of lumen problems, it can cause secondary hypertension. Next one, drugs. Some drugs also can cause hypertension, that is non-steroidal anti-inflammatory drugs. Some of drugs have side effects. It will cause hypertension. Next, steroids, oral contraceptive pills, and some sympathomimetics also can cause hypertension. Okay, so these are the causes of primary and secondary hypertension. So we can see the primary causes of hypertension like risk factors, that is age. Based on when age is increasing, the stress levels will increase, so it can cause the hypertension. Next one, male gender. Because of increasing more amount of stress levels, it can cause hypertension. Compare with females, males will not going to share everything, so the stress levels will increase. In females, whenever they have problems, they will express. So because of age is very important, so males are very prone to get hypertension. Next one, family history. In family, like mother or paternal have any hypertension issues, the children also will get hypertension. So family history is very important. Next one, obesity. How obesity will cause hypertension means, whenever if you are seeing obesity cases, the body mass index will increase, so fat will increase, so the fat will compress the blood vessels. Because of the thing, the blood vessel become narrow and it will cause hypertension. Next one, high salt intake. Whenever we are taking more amount of salt, the salt will increase more amount of fluid in our blood vessels. So because of salt, increasing fluid will cause volume overload and it will cause hypertension. Next one, sedentary lifestyle, no exercise, always sitting things because of their job and everything. This sedentary lifestyle also will cause obesity and it can cause hypertension. Next one, stress levels. Next one, smokers. Whenever patient taking any smoking, if they have smoking habit, the nicotine will increase constriction of the blood vessels. So because of the thing, the smoking also will cause hypertension. Next one, alcohol. So these are the risk factors will cause primary hypertension, risk factors and causes. Okay. So next one, pathophysiology. This pathophysiology is very important. If you are seeing this image, the hypertensive stimuli we can see because of oxidation, mechanical stress, protein fragments, etc. We can see the renal injury because of the thing, neoantigen formation and presentation. The T cell will get proliferation and migration and infiltration, and the heart, the right atrium will release one hormone that is we call natriuretic peptide. So that natriuretic peptide will reduce. Because of the thing, patient will get hypertension. And another thing, because of genetic and environmental factors, it will activate sympathetic nervous system. Because of increasing sympathetic nervous system, the sympathetic nervous system will activate RAS mechanism. RAS mechanism means renin angiotensin aldosterone system. If you are seeing here, whenever the blood pressure is drops or the fluid volume will reduce, the liver will release one mechanism, that is angiotensinogen. The RAS mechanism will activate. The angiotensinogen will release from the liver, and the kidney, whenever the blood pressure is reduced, in kidneys, in nephrons, we can see one juxtamedullary arteries and medullary cells. That medullary cells is very sensitive to hypotension. So whenever the blood volume reduce, the kidney will activate and the kidney will release angiotensin and it will release renin. The renin will release from the kidneys and it will activate the angiotensinogen and it will convert into angiotensin 1. The renin will act on angiotensin to form angiotensinogen and angiotensin 1. Then after, if you are seeing in bronchioles, the bronchioles will release one hormone, that thing we call angiotensin converting enzyme. It will release from the lungs in bronchial part. So then after it will release, and the that angiotensin converting enzyme will acts on angiotensin 1 and it will form angiotensin 2. Then angiotensin 2 will go to blood vessels and it will act on blood vessels to stimulate vasoconstriction. So then the blood vessel will become narrow. Whenever the blood vessel will become narrow, it will cause hypertension, right? So in angiotensin 2 acts on adrenal gland to stimulate aldosterone. So here we can see the aldosterone will accumulated. Then after, the aldosterone acts on kidneys and it stimulates reabsorption of salt and water. So whenever the kidneys reabsorption of the salt and water, the hypertension will increase. So if you are seeing here, the vasoconstriction will reduce, the sodium and water retention will increase. So the peripheral vascular resistance will increase, so the blood volume also will increase. So it can lead to sustained hypertension. Problem is, if any patient have hypertension, the symptoms we can't see because the patient will be like asymptomatic. If that hypertension damaging the target organs, then it will cause symptoms. So we can say target organ damage like heart, kidney, brain and eyes. In heart, it will increase the heart ventricles, so the ventricles will become thick. In kidneys, we can see that tubules, everything will become thick and it will cause more amount of reabsorption and it will cause more amount of hypertension. Next one, brain. In brain, it can cause hemorrhage or increasing of ischemic attacks and this type of things. Eyes. In eyes, we can see retinopathy or retinal hemorrhage because in eyes you can see very narrow blood vessels. The blood vessels will become rupture. Okay, so these are the things will happen in blood vessels, coarctation of aorta or aortic dissection. These are the things will happens. Okay, so these are the complications, these are the target organ damage issues. So next you can see here clinical features. In clinical features, if any patient have hypertension, we can see signs. In signs, elevated of blood pressure and repeated measurements, and we can check in fundoscopy. We have to check arterial venous nickeling and hemorrhages and papilledema. In malignant hypertension also we have to check fundoscopy. Next, left ventricular hypertrophy signs, and if patient have coarctation of aorta, the radiofemoral delay we can see. Next one, symptoms. In symptoms, mostly asymptomatic, that's why we are telling that is hypertension is the asymptomatic and silent killer. If patient like target organ damage happen, means we can see some mild symptoms, that is headache, dizziness and palpitations, and sometimes visual disturbance. If patient getting blood vision or eye related problems, then we can see visual disturbance and blood vision. And in heart related things, chest pain and difficulty in breathing. So next one, investigation. In investigation, we have to do basic workup. So what are the things? First of all, we have to check blood pressure measurements. In blood pressure, if it's like more than greater than equal to 140/90 mmHg, then we have to suspect that is hypertension, because if less than 120/80 mmHg means it will become like normal. It is like normal only. If you are suspecting comorbidities, we have to check fasting blood sugar levels for diabetes screening. In fasting blood sugar levels 70 to 100 milligram per deciliter. If you are suspecting kidney injuries and anything, we have to check serum creatinine and excreting glomerular filtration rate. We have to do renal function test. In that renal function test, if creatinine level 0.6 to 1.2, it is like normal. EGFR greater than 90, it will be like normal. So next one, lipid profile. In lipid profile, we have to check low density lipoprotein, the cardiovascular risk, and if low density lipoprotein less than 100 milligram per deciliter, then we have to suspect that is hypertension. Next one, urinalysis. In urinary analysis, we can see proteinuria, and it can cause if negative means we don't want to check proteinuria, because why we have to check? Hypertension can cause nephritic syndrome or nephrotic syndrome, so that's why we have to check. Next one, ECG. In ECG, left ventricular hypertrophy and arrhythmia, these are the things we can see in hypertension cases, and normal sinus rhythm. And echocardiography means ECG, and cardiac target organ damage and normal ejection fraction and structures. And fundoscopy also we can do for suspecting retinopathy and normal retina. So these are the normal investigation workup, basic workup we have to do. Okay, next one, how we can diagnose the patient and how to do severity grading means. For diagnosis, we have to confirm, before confirming the hypertension, we have to check average like 2 to 3 readings on greater than equal to 2 occasions. If that blood pressure is increased, it's not reducing, then we have to suspect that patient have hypertension. But that occasions is important, the number 2 to 3 average readings is important. How we have to do severity grading means, we have hypertension like three different stages: stage 1, stage 2, stage 3. In stage 1, mild cases, we can see like systolic blood pressure 130 to 139, the diastolic blood pressure like 80 to 89 mmHg. In stage 2, we can see moderate cases greater than like 140 to 159, the diastolic will be like 90 to 99 mmHg. In severe cases, greater than equal to 160 by mmHg, greater than equal to 100 mmHg of the diastolic blood pressure. So based on mild, moderate, severe, we are going to treat the patient. If you are seeing here, this is the chart for treating mild, moderate and severe. So in mild cases, if you are seeing like clinical reading greater than equal to 140 by 90 mmHg, we have to offer like acute blood pressure monitoring or high blood pressure monitoring. So if patient like less than 135 by 85 mmHg means it's like not hypertensive. After doing 2 to 3 occasions and greater than equal to read like average readings means the patient have not hypertensive and we have to do monitoring. Next one, greater than equal to 135 by 85 mmHg. Here we can see stage 1 hypertension, and we have in if patient like we have to treat if less than 80 years and none of the following. If we are suspecting like target organ damage, then we have to, if you are suspecting cardiovascular disease or renal disease, diabetes, at 10 years of cardiovascular risk, 10% of greater means, then we have to start drug treatment for hypertension. If you are suspecting like stage 2 hypertension greater than 150 by 95 mmHg, then we have to treat all patients based on that patient age. Okay, next one, how to do management. First of all, we have to reach the goals. We have to reduce morbidity and mortality to prevent cardiovascular and renal complications. We have to follow some general measures, and we have to treat pharmacological management. We have to treat the cause, and we have to follow up, and we have to monitor the blood pressure always. So we have to do, before treating blood pressure, we have to do lifestyle modification. In lifestyle modification, we have to do weight loss. In weight loss, the body mass index 18 to 25 mmHg, and we have to do salt restriction like less than 5 grams per day, and we have to do we have to give patient education to do regular physical activity 30 minutes per day, and we have to limit the patient. If patient have habit to drink alcohol and smoking, we have to counsel that patient to stop, like we have to quit. The patient have to quit. Next, DASH diet, to fruits, vegetables and low fat dairy and less salt food patient have to consume. Next, stress reduction, for doing like yoga and meditations and spiritually growing and increasing listening music, peaceful musics. Next one, we have to monitor blood pressure at home. Okay, so these are the lifestyle modifications the patient have to do. Next, in first line management, we have to treat that patient based on drugs. So first, we have some drugs. That is, first one, amlodipine. The amlodipine is the calcium channel blocker. We can give that patient like 5 to 10 milligram orally, and OD long term. In first line management, the contraindication like peripheral edema, it can cause and reflex tachycardia. Next one, lisinopril, means ACE inhibitors, angiotensin converting enzyme inhibitors. The dosage will be like 10 to 40 milligram orally, and OD long term. And for first line drug for chronic kidney disease patient and diabetes mellitus patient, we can use first drug is ACE inhibitors to protect kidneys. And we have some contraindication side effects, that is, it can cause cough and hyperkalemia, and for pregnancy people, pregnancy women, it can cause teratogenic. So third one, losartan, means angiotensin receptor blocker. So we can the dosage like 50 to 100 milligram orally, OD, and long term. For it, we can use first line drug. If the ACE inhibitors is not enough intolerance, then we can use ARBs. But the side effects is it can cause hyperkalemia, same to same like ACE inhibitors. It will cause in pregnant women. It can cause teratogenic. Next one, hydrochlorothiazide. It's like thiazide diuretics. We can give 12.5 to 25 milligram orally, OD long term, and the first line drug in like young ages. And we can give the side effects is hypokalemia, and it can cause hyperuricemia. So whenever patient coming with gout, if that patient is using hydrochlorothiazide, HCTZ, thiazide diuretics, we have to stop the drug. Okay, next one, metoprolol. Metoprolol means beta blocker, 50 to 100 milligram orally. We have to give BID long term. If patient like stroke patients or coronary artery diseases or post myocardial infection and heart failure patients, we can use metoprolol. But in asthma patients, that is asthma, contraindicated to asthma patients because it can constrict the blood bronchioles, and the asthma will become severe, and bradycardia. This is the side effects. Next one, spironolactone. The spironolactone is the aldactone potassium sparing diuretics. We can give the dosage like 25 to 50 milligram BID, oral OD. Long term we can use for resistance of the hypertension, and in the contraindication is it can cause hyperkalemia and it can cause gynecomastia. So these are the first line management for hypertension. So next you can see here, based on patient age we can treat. So this is the stepwise approach for pharmacological management. If BP targets like for reducing and maintaining blood pressure, if age like less than 80 years, the clinical blood pressure like less than 140 by 90 mmHg means acute blood pressure monitoring. While doing high blood pressure monitoring, less than 135 by 80 means based on that age we can change the medication. If age greater than equal to 80 years means if clinic blood pressure like less than 150 by 90 mmHg, while doing blood pressure monitoring, if less than 145 by 85 mmHg, or postural hypertension based on target on standing orthostatic hypertension, this type of things if the patient have means, based on this thing we have to we have to give drugs based on age in geriatrics. Okay, if you're seeing here, this is the step by step approach how to give regimens of the hypertension management. If less than 55 years age means we have to use first step 1 drug, we have to use ACE inhibitors. If ACE inhibitors like ramipril, okay, or esinopril, captopril, these are the drugs will comes in ACE inhibitors. So these are the drugs we can use in step 1. If after that the patient is not getting enough dosage, then we have to increase dosage. Still that blood pressure is increased means then we have to add ARBs, means angiotensin receptor blockers. Okay, in step 2 you can go with angiotensin A's and ARBs, and you can go with calcium channel blockers or thiazides or diuretics. Okay, next one, in severe cases you can use ACE or ARBs, or you can use calcium channel blockers, or you can add diuretics also. Next one, you can see greater than equal to 55 years means if patient have no diabetes and the patient is black and African or Caribbean ethnicity means we can use calcium channel blocker first drug, because Africans don't have any angiotensinogen, it's not going to release, so it's not going to work. So that's why we have to use calcium channel blocker. Okay, in step 2, calcium channel blocker or ACE inhibitors or ARBs, or calcium channel blockers and diuretics. Okay, in severe cases if potassium less than 4.5 means we can add spironolactone, because it's potassium sparing diuretics, it can increase hyperkalemia, so that's fine. If potassium greater than 4.5 means we can add alpha and beta blockers. If blood pressure not controlled means we have to add these 4 drugs like ACE inhibitors, ARBs, calcium channel blockers, diuretics, or we have to refer to hypertension specialization. So here we have some side effects and we have some contraindications. For ACE inhibitors, the common side effects is cough, angioedema and hyperkalemia. The contraindications for pregnancy and bilateral anal artery stenosis. Next one, ARBs. In ARBs, hyperkalemia and dizziness, and it can cause a contraindication for pregnancy. Thiazides, the common side effects is hypokalemia and hyperuricemia. In contraindication, we can use severe renal failure, that is a contraindication. Calcium channel blocker, common side effects is edema and headache, and contraindication will be like hypotension and heart failure. Beta blockers can the side effects is it can cause bradycardia and fatigue. Contraindication, if patient have asthma and AV block, we can't use beta blockers. Next one, spironolactone, side effects is hyperkalemia and gynecomastia. If patient have contraindications of renal failure and hyperkalemia, we can't use spironolactone. Complications, if patient have In heart, we can see left ventricular hypertrophy and heart failure and myocardial infarction. In brain, we can see stroke and transient ischemic attack. In kidneys, chronic kidney disease and proteinuria and nephrotic syndromes. In eyes, we can see hypertensive, retinopathy and papilledema. How to do follow-up means in blood pressure monitoring in home or office every 1 to 3 months initially. And we have to check labs routinely like renal function test, electrolytes and lipid profile early. And target organ evaluations we have to do like ECG for checking heart and echo for checking ejection fraction and fundoscopy for checking eye related things. Next one, adherence and lifestyles for reinforce to each visit. Okay, so these are the follow-up and monitoring. So if you didn't subscribe my channel, like, share and subscribe. In this video we covered everything about hypertension. If you have any doubt, you can ask me in comment section. So till that time, bye bye and take care. Let's meet in our next video.